All right, everyone, good afternoon. I hope that so far your March has been going to a positive, upbeat drumbeat as we're all moving forward finally into spring, some warmer weather, although it's a little late in coming here. But we just want to thank you so very much for joining us today for our virtual symposium on peer respites. What, how, and why? My name is Katie Rouse, and I am lucky every day to serve as the Executive Director of On Our Own of Maryland. On Our Own is a statewide peer-run behavioral health education and advocacy education organization, and we have just celebrated 30 years of peer empowerment and systems transformation last year. So just a big huzzah to all of us in the network and everyone, peer leaders who have really helped to transform our behavioral health system. As we get started with our symposium, I do want to share just a few opening notes, which is mostly to say that we're here today to talk about how peer support and peer respites create healing alternatives for folks experiencing emotional distress or crisis. You are going to hear some wonderful perspectives today on what that means in real life, and we hope that you will share those learnings with your community and that you will spread the word about our feasibility project we're doing right now to explore how we can bring more peer-run alternatives and peer respites into Maryland. I also just want to say a very big thank you to the GBRICS partnership and to Behavioral Health Systems Baltimore for being our partners in this project and for so generously making it possible for us to hold this symposium today. So if we could take just a moment to center ourselves in our values of equality and justice and autonomy and choice, which I hope and I believe and I know are really the heartbeat of our symposium today. So with that, let's see who we are in the room with a short poll. Michael, if you will be so kind to launch that poll. There we go. So just 3 questions for us to understand kind of who we are and why are we here. How much do you know about peer respite? Have you taken our survey yet? And have you ever, at any point in your life, used any sort of behavioral health support services? Like all things, the poll is voluntary, but it's great to know kind of how we came to be here today. So I'm seeing a lot of folks, 58, 60% are saying that they have some knowledge of peer respite already, which is great. We're going to take a deeper dive with some subject matter experts. I'm seeing the not yets coming out ahead of the yes on our survey. So Marcy will drop the link in the chat at the end of this session, and we really would be appreciative of you taking 5 to 10 minutes to let us know kind of what your experience has been. And have you ever used behavioral health support services? Unsurprisingly, the vast majority of us on this call today have at some point in our lives sought out support for a behavioral health challenge that we were going through. So thank you all so much for the poll results. I'll just share those so that we're all understanding who's in the room. I think this is going to be a great learning experience for all of us. And thank you, Michael, so much for launching that poll. So we have really just a wonderful buffet of information to share with you all today. Lots of folks, we know there's going to be lots of questions. So I will ask if you'd please use that chat feature throughout the symposium. If you have questions, we will get to as many as we can with the time that we have allotted for each phase of our symposium. But with no further ado, please let me introduce our first speaker. Dan Rabbitt is the Policy Director for the Greater Baltimore Regional Integrated Crisis System, sometimes called GBRICS, that partnership at Behavioral Health Systems Baltimore. And since landing here, he and the team at BHSB have really been a champion of advocacy on topics like crisis services expansion, the 988 Trust Fund, and this peer respite feasibility study that brings us here today. So welcome, Dan. Thank you so much for being here. The mic is yours.
Great. Thank you, Katie. Good afternoon, everyone. My name is Dan Rabbitt. I work at Behavioral Health System Baltimore, as Katie mentioned, and have been on board helping to support the GBRICS partnership, as well as the launch of 988 for about 2 years. I'm very excited about this project and our ability to help support it and partner closely with our friends at On Our Own of Maryland. And so great to be with you all today. Next slide, please. Like Katie said, this is comes out of the GBRICS partnership, the opportunity to do this study. what the GRICS partnership is it's a 5-year, $45 million grant that BHSB and dozens of other partners in the region sought out in 2020. The grant, we were able to get the grant. It started in 2021, and it is a 5-year project that goes from 2021 to 2025. So we are coming up on the halfway point, which is just bananas. But what the idea behind this grant was that the funder was the Health Services Cost Review Commission, which Maryland, it's the entity that manages hospital dollars. And this entity thought about all the different innovations in healthcare and wanted to invest in a couple of promising practices that had the potential to improve care and lower hospital costs. And they landed on only 2 projects. One was around diabetes care, and the other was around behavioral health crisis response. And so the HSCRC put out this grant in 2020, and the GRICS partnership came together to pursue it. We're very lucky to have it. It's having 5 years, having this amount of funding, and having this amount of buy-in across 4 jurisdictions is a rare place to be in the system change world. And so we are thrilled to be working on it. The idea behind the GRICS partnership initiatives was to build on the strengths of our current crisis system, which is robust and has been around for a long time, to make it even stronger and expand its capacity even further. We came together with all of the hospitals in these 4 jurisdictions, as well as our partner LBHAs in the region. I should also say BHSB, where I work, is the local system manager, local behavioral health authority, as it's called, for Baltimore City. So we oversee the full range of mental health and substance use services in the city. This partnership took us out of the city to work on a regional level. And so we're working very closely with our fellow counties and hospitals and partners and BHA, who the Behavioral Health Administration, who I know is also on the call and a big partner. BHSB, this isn't our show. We are really as a convener. We manage the day-to-day project management, manage the contracts, but it really is a region-wide, system-wide initiative, and we're just kind of trying to keep the trains running on time. Next slide, please. The goal of the GRICS partnership is to reduce unnecessary emergency department use and police interaction during a behavioral health crisis. That's really our gold star, or our North Star, excuse me. And everything that we're doing is in service of trying to achieve that goal. This project came into being by an additional grant that we received from the state to help us in achieving that goal. The state has had a lot of funds lately with the coronavirus relief packages that have come down the pike. And so we were very privileged and grateful to receive a little extra funding that's allowing us to do this study. And peer respite programs, we think, could be an additional element to what the elements that you see on the screen. These 4 elements are what were included in the original proposal, the plan for the GRICS partnership. But we know that these 4 things alone is not everything we could do in service of trying to reduce unnecessary ED use and police interaction for folks in serious distress. These 4 elements, just to go over them quickly, if folks are familiar with the Crisis Now model that talks about someone to call, someone to respond, and somewhere to go as the 3 elements of good behavioral health crisis care, this will be familiar. The regional call center that we're setting up is that somewhere to call. And we are taking the existing helplines that are in the 4 jurisdictions currently and consolidating them into one regional call center with sophisticated technology to help not just answer calls, but dispatch mobile crisis teams, make referrals and appointments to other services, and improve our data collection. The second element is to expand mobile response teams. These are civilian teams, non-law enforcement teams of mental health professionals who can go out into the community to meet with someone where they're at if they need that level of care during a crisis. And we are significantly expanding the number of teams that are available. These teams exist already before GBRICS, but we are adding to the continuum of different teams that are out there. The third element is open access services. This is working with the existing continuum of community mental health and substance use treatment providers to help them offer same day or next day appointments for people who need an immediate appointment due to a crisis. And then the fourth piece that sort of underpins all of this is our community engagement and outreach campaign, which kind of supports it all. Like the only way that these services are going to work is if the communities that are intended to be served are bought in, trust these services, and are aware that they're out there. Next slide. So at the same time that GBRICS is happening, kind of by a little bit of serendipity, Congress also created or started the process to transition to a new 3-digit helpline for the whole country, which is 988 for folks who may not have heard of it before. And so 988 is serving as the front door to all of the services that I just mentioned, and is a huge component of making the GBRICS partnership funded services work well. The regional call center that I mentioned that we're standing up that with the consolidated local call centers is being operated by the 3 organizations you see down there at the bottom, BCRI, Sante, and Grassroots. They are also the lead crisis service providers for mobile crisis teams as well in the 4 jurisdictions. And kind of this whole package and the regional call center itself is now called the Call 988 helpline. So you might see that around in the region. Next slide. In support of 988 and getting the word out around 988 and improved crisis services, we are also engaging community partners in a number of ways. We have a 988 helpline website. We have a bunch of promotional materials for 988. We're working with community partners to get the word out. We are engaging in paid digital and search advertising, and are planning a second promotional campaign targeted at youth later this year. And so all of that is helping to raise awareness of 988, helping to reduce stigma around seeking help when you are in distress, and kind of is the front door, like I said, to all of the other services. And all this package of initiatives that the HSB is working on is kind of where peer respite programs could sit for the region. And the services that peer respite programs provide, as you're going to hear, kind of complement 988, outreach and community engagement, mobile crisis teams, supportive counseling through 988, call takers, and kind of can be a part of this continuum potentially. And that's why we wanted to learn more about how this initiative or this model could be of service. So that's sort of just the background of like how we got here, and excited to, I think, pass it back to Katie and hear more of the conversation. Oh, I did have one more slide, but all that is to say is that all of this is great. 988 is great. GBRICS is great, but we have more to do in order to truly build the system that we need, and peer respite programs can be a part of that.
Dan, that was perfect. Thank you so very much. It's really helpful to understand the context and all the work that's being done. We're just so lucky, honestly, in Maryland to have transformative work, that's been building for years. And it's happening on the local level, on the regional level, on the statewide level. We are, when we look across the country with the advent of 988 coming, kind of where all states are. We're really lucky to be in Maryland, where we have very visionary, hardworking leaders who've been, recognized what we need to do to enhance and expand support for people experiencing distress early, and have been building towards that. Speaking of incredibly dedicated, hardworking agents of change working in our state behavioral health system, I would like to please introduce you. Many of you know, but to say a very warm welcome to Cherene Lipford of the Behavioral Health Crisis Services System and Emergency Management Division, and Brendan Welsh, the Director of the Office of Community-Based Access and Support from BHA, to talk to us today a little bit about kind of where they see peer support in the crisis continuum of care. So Cherene and Brendan, thank you so much for being here. You're absolute champions. The floor is yours.
Thank you very much. I'll kick it off by, I'd like to start actually with a very short quote that I stumbled upon today. The quote is from Shannon Alder, who is an author. And what she says is, one of the most important things that you can do on this earth is to let people know that they are not alone. And I thought that the quote really resounded with me and speaks to the work of all of what you do and what you bring to the behavioral health system and the care and support system, as well as just our ability to help and lift other people up. And that is the perfect segue into the crisis system. So in February of 2021, the Behavioral Health Administration launched the Maryland Crisis System Work Group. And the idea, the journey really has been to develop an integrated, comprehensive crisis system that serves all ages across the population, so children through senior adults, and serves people that are experiencing both a mental health and substance use crisis. So that's been the foundation. And as Dan said and shared, our model really is based on SAMHSA and national level best practices. We're working to create a system where folks have a place, someone to call, a place, someone to respond, such as mobile crisis teams, outreach teams, and a safe place to go. So that has been our work to really provide the structure. We launched 5 work groups to help set the foundation. Just to level set, a lot of crisis services have been in operation and underway and been funded by the Behavioral Health Administration for over 20 years. But we really are capitalizing on the national momentum and the local and the state momentum to build and move this system forward collectively, which I think is what's a little bit different. So very quickly, let me just highlight some of the successes that are currently in place. In every jurisdiction in Maryland, we have 988 and call centers. We have 20 out of 24 jurisdictions that are currently operating mobile crisis teams. We have all of our mobile crisis teams are currently being trained in a best practice model for children, youth, and families. And that model is called Mobile Response and Stabilization Services. We have 19 walk-in centers that are based across Maryland. We have peer recovery specialists who are funded and working in urgent care centers. And we have over 254 residential crisis beds to serve people with both mental health and substance use needs. So the work is underway, and we're delighted to be here. And on behalf of BHA, we just want to say thank you for all of your hard work and your dedication. Brendan?
Thank you, Cherene, and thank you to Katie for inviting both of us to come today and speak. Before I get into specific numbers about peers and the crisis service, I think it's really important to take a look back just 6 short years ago at what was being funded for peer services specific to the mental health portion of those seeking wellness and recovery. And at that time, when I started in this position, our service selection being delivered by peers in the mental health community was very much limited to our Wellness and Recovery Center investment here at the state, which was only a little over $2 million. Now, in the 6 years that have followed, that investment in and of itself has doubled now to more than $4.2 million, supporting those existing centers, getting them some much needed infrastructure boosts. The other area we've really made significant gains in, and our first time really expanding peer support across the mental health arena outside of our wellness centers, was in fiscal year 2022, when ARPA funding became available and we were able to initiate the Behavioral Health Urgent Care Peer Expansion Project. This funding project took an additional $2.2 million allocation over the 4-year funding period, and it's allowing us to support hiring peer recovery specialists within crisis walk-in centers. And so to achieve this effect, we coordinated with BHA's Crisis Services Office, that's where Darren and Cherene work, to help ensure that our peers were being embedded within other state-funded crisis programs that had already been established within the state or were soon to be coming online. And so through that effort, we were able to hire a total of 6 different peer positions through our local authorities to support services in 5 different crisis walk-in centers. And those programs are located across the state with representation in Frederick County, Harford County, Howard County, as well as St. Mary's and Worcester County. In the previous fiscal year alone, fiscal year 22, there were more than 697 individuals that benefited from crisis walk-in peer support services. And those 697 individuals participated in more than 1,000 individual peer services during their time in the center. And these services look much different depending on the type of support that the individual needs at that time. But ultimately, the end goal is to make sure that these peer relationships end in connections back to community-based supports that help that person's wellness long-term and ultimately prevent a reoccurrence into the crisis center. Because that's what peer support is all about, is that long-term support and ongoing support. And so as of January 1st, 2023, I think it's also important to note that across the state, across all of our different behavioral health settings, we have 386 peer positions that are funded by BHA, all waiting to help support individuals as they come out of crisis services and back into community settings where they live at home. And these peers are embedded in different services, including the wellness and recovery centers I mentioned early on. We have peers working in outreach positions within the different communities across the state, as well as our clinical levels of care like our hospitals and treatment centers. We've even expanded into now non-traditional settings such as courts and jails, and hopefully soon, as a result of some of this work, peer respite centers in the near future. So thank you again to Katie and On Our Own on all the work they're doing, and BHSB for funding this opportunity. We look forward to partnering with all of you guys in the future, and thank you for all the work you're doing.
Oh my gosh, Cherene and Brendan, thank you so much for being here, for your strong support over many, many years. It is really in taking a step back and recognizing like how long the journey has been and how much progress has been made, and knowing that there's a really strong foundation there and understanding of where we can go from here, because for sure the opportunity is there and we're ready for it. So thank you again for everything and for being here. So folks, big picture, I hope that really helped paint a landscape of where we are when it comes to crisis support, where we are when it comes to the role of peers in that continuum, all the ways where we've added, enhanced, expanded, and also where we know there's still a lot of work to be done. So with all of that, right, where can peer respite fit into this framework? Where does it fit best? And how do we make that a reality? And to answer that question, we are so glad and fortunate to have some wonderful subject matter experts who are joining us in our feasibility study to look at this in the Driebix region. So with that, I am going to turn the mic over to our project team partners, Travis Atkinson of TBD Solutions and Cherene Caraco of Promise Resource Network, who are going to introduce themselves and take us through an overview of this feasibility study. Cherene and Travis, take it away.
Thank you so much, Katie. Good afternoon, everybody. It's a pleasure to be here with you. Thank you so much to Daniel and Cherene and Brendan for just doing a great job of kind of setting the table for this discussion today as we dive into the concept of a peer respite and what it would look like to have a peer respite available to individuals experiencing an emotional distress or mental health crisis in your communities. My name is Travis Atkinson. I'm the Director of Clinical and Crisis Services at TBD Solutions. Much of my job is being a student of the crisis continuum across the country and understanding how communities are responding to people experiencing one of the worst days of their life in a way that is compassionate, that is thoughtful, that's evidence-based, and ultimately that is helpful. So I'll turn it over to my partner, Cherene.
Thank you so much, Travis. Hello, everybody. Good afternoon. I can't even tell you what an honor and a pleasure it has been to serve as a consultant with you all on this project since January. My name is Cherene Caraco. I am the Chief Executive Officer of a peer-run organization in Charlotte, North Carolina called Promise Resource Network. We do operate one of the peer-run respites in the country, and I work with several states around the country as we speak to start up some of their own peer-run organizations and some of their own peer-run respites. I am also a psychiatric survivor and am very open about my experience throughout many, many years, decades of experiencing mental health challenges, being a suicide attempt survivor, a trauma survivor, and now using that information to help support our crisis continuum around the country. It is so great to be here.
We can go to the next slide, please. So when we talk about a behavioral health crisis continuum, it's important to know what that includes. Every community's crisis continuum is different, but it's safe to say that many include, let's say, between 3 and all of the parts of this system that we see in front of us. So for a person who's in crisis, we have available to them crisis call centers, mobile crisis teams, psychiatric urgent care centers, 23-hour crisis stabilization units, crisis residential units, and partial hospital programs. Those are kind of what we normally consider to be outside of the traditional medical model of behavioral health crisis. Now you notice the peer respite circle down there in green. We'll be talking about that one today. But then also at the top is the emergency room in the psychiatric hospital. These for decades have been traditional methods by which people have received emergency psychiatric care. Unfortunately, in the case of the emergency room, it wasn't designed to serve people experiencing a behavioral health crisis. And if you've ever been in the emergency room for any reason, you know that there's a lot going on there that can be detrimental or cause an increase in symptoms for a person who's in emotional distress or who's struggling. It can increase agitation with the lighting and the sound and just so much going on. But really, emergency departments essentially are not treating people with mental illness. They are trying to find a place for them to receive treatment. And historically, for many communities that have not had these options in blue and green below, if all you have is a hammer, then everything looks like a nail. And so when you only have a psychiatric hospital, then many more people look like they belong in the psychiatric hospital. And having these options like peer respite is very important in the interest of right-sized treatment for a community. Next slide. So the Peer Respite Study began in January of this year, and it runs through June. It was funded through the GBRICS initiative and involves a number of steps to achieve the completion of a feasibility study to understand what is going to be needed to possibly bring peer respite into the communities in the greater Baltimore area. So these steps include stakeholder meetings and interviews. They also include on-site visits of crisis services like Baltimore Crisis Response, for example, an analysis of crisis service utilization data. Now, we understand that there was a pretty heavy lift of data collection that happened in your community or in the state in the last year. So one of the sources that we're leaning on is that previous data collection to look at things like how often are emergency departments utilized by people with a behavioral health disorder or behavioral health condition, or how often are psychiatric hospitals used compared to crisis residential programs. And then all of this information that we're collecting and taking in leads to the creation of a recommendations report, which we will be presenting to the community in June. Next slide, please. So I'll turn it over to Cherene to kind of introduce us to the peer respite model.
Thank you, Travis. So I'm going to give you a really big picture overview. So 30,000 square feet looking down in a peer respite, and just a little bit about what it is and how it operates. We are very fortunate that after the break, we have 2 folks that operate peer-run respites that will be joining us, Steve Miccio and Vesper Moore, who will be getting into more of the details of how their peer-run respites operate, how they operationalize these things on the ground. So just in general, a peer-run respite is a healing alternative to emergency department, inpatient, and involuntary commitment for folks that are experiencing mental health related crisis. People ask a lot, what do you mean by mental health related crisis? And what I say is any mental health crisis that would otherwise land somebody in an emergency department, in an involuntary commitment, or even in an inpatient setting are the reasons why people show up for peer run respites. So it can be anything from I'm having thoughts of suicide, I'm hearing voices that are distressing to me, to I'm having a disagreement in my family and I really want to work through it. Or, this is the anniversary of the death of a loved one. And every year I end up in the hospital and I want to avoid that this year. So you will see throughout the presentation that there are a variety of reasons why people come to a peer run respite. In general, they are an alternative in the array, as Travis said, to some of these higher, more intense, more expensive, and more confined based spaces like emergency department and inpatient. Next slide, please. So peer run respites are not new. Actually, currently, the last documentation that we have been able to put our hands on, we have 40 respites spanning 14 states. I will tell you that right now in Oregon, there are 5 respites that are coming up. Connecticut is working on starting up 5 respites. California, different regions of California are in the operational phase of starting up some respites. My own state, we're starting respites. So when I say 40 respites in 14 states, recognize that that is really evolving as 988 has come into our communities, as emergency department boarding becomes a significant issue, as we're recognizing the needs for alternatives to police intervention and alternatives for confined spaces. More and more states, communities, counties, and cities are looking at the peer run respite model, which is not new. It actually began in the 1990s. There are actually some other examples before the 90s of precursors to peer respites. So it's not new, but it is very much catching on. One of the things I love of what you are doing in the Baltimore region is that you're getting in front of this and taking a look at the data, looking at the stakeholder engagement, what would work in your community, various models of respites, and being really strategic about the idea of a respite coming into your area. You will see that a respite is a departure from traditional mental health crisis care. So as a matter of fact, on the slide, we have 2 pictures of 2 respites in the country. I know Steve and Vesper are going to share a whole bunch of pictures for you of the respites that they operate, but it is a departure from traditional mental health services and crisis care in many ways. And the next slide will start to build that out a little bit. Next slide, please.
So as Cherene said, not only is peer respite prevalent in the United States, it's also well researched. The evidence and the outcomes from the research findings over the last 10 to 15 years demonstrate lower hospital and healthcare costs for people who are utilizing peer respite. They have a greater optimism about their recovery. The studies also show a reduction in symptoms such as depression or anxiety, and increased self-direction or self-confidence about where they want to go and where they're at in their recovery journey. So important to keep in mind, it's one thing to have a feeling or a sense that peer respite is helpful, but it's a very nice addition to also know that others have not only tried this out, but they have gone through the process of studying the model and understanding its efficacy too. Next slide.
So here's some of the characteristics. You saw from the pictures, peer run respites are in a home, in a neighborhood, in a community. They're not in a unit. They're not on hospital grounds. They are not in a medical environment. They are literally in a house, in a neighborhood, in a community. Respites are typically unlocked. They are voluntary and they are non-coercive. It's really important that those 3 characteristics remain a part of the respite model. Unlocked because so many folks want to avoid locked settings because it feels harmful, it feels re-traumatizing, and there are not a lot of options available when somebody's experiencing a crisis that is voluntary and unlocked. This adds to the array of options that are available to people, and it's done in a way that is much more trauma-informed for the folks that are coming in. So it's important these 3 characteristics remain involved. We take non-coerciveness so serious in our peer run respites that we don't even want conversations with people about, well, you either choose to go to emergency department or you go to the respite. We want the respite to be chosen by the person as the environment that feels helpful and healing in that environment. So respites are non-clinical. So they also are one of the only options available in a crisis array that are intentionally non-clinical. That means that somebody isn't coming into a respite for a medication adjustment, as an example. And our worldview in a respite environment is really through the lens of what is going on in your life experiences, what has happened in your experience. We're looking through a trauma lens. Because it is a very trauma-informed option, it is also peer operated, meaning that all of the folks that operate the respite and staff the respite are people that have been directly impacted by mental health related crises, having been involved in crisis services and systems, suicide attempt survivors, and folks that have experienced voices and different variations of mental health issues. One of the unique things about a peer-run respite, because it is unlocked, it is also an environment where people can maintain outside relationships and outside identities. So one of the things that happens, as we know, when somebody gets hospitalized is oftentimes it disrupts your employment, and it could even lead to losing your employment. People feel uncomfortable about, how do I share with my employer that I was actually in a hospital environment? Will that risk my employment? Or the one positive thing that I have in my life is my job, or it's school. And now I'm being taken away from those things. So in a respite, people maintain employment if they choose. If they want to take time off and suspend their employment, they can do that. They maintain their education if they choose, and they maintain the relationships and the community connections that they come in with. You will see by talking to Vesper and Steve that the length of stay for a respite really varies based on the model, the community, the resources, and the needs. We have seen respites that are 3 days in length, 5 days in length, 7 days, 10 days, 14 days. You get the point. Length of stay really is determined by a variety of different factors that we want to be able to consider. But we're going to put that in the report as some options for you all to think about when you're choosing the model of the respite that you're going to have. And the operating costs are also varied. I believe Steve has a slide in giving you some of the data and some of the funding and cost savings, but the operating costs depend on a couple of things. Number one, the location, whether you're going to rent, lease, buy a home, and where that home is located. The number of guests that you have. I have seen respites with 2 guests and 3 guests. Some have 5 and 7. Well, obviously that's going to dictate the space issues that you have, and that's going to dictate costs. It's also going to be determined by your staffing and how you end up staffing the respite. I will tell you in general, for our respite in North Carolina, it is about $150 a day per person to operate the respite. And in our state, it's about $2,500 a day for an inpatient stay. And so you can see right there the differentiation in expense and costs, and obviously can imagine the cost savings for a peer-run respite. A couple of other things in the time that we have left. A peer-run respite, typically guests come in, they have their own private room. You will see pictures of that. And the environment is really critical to a peer-run respite's comfortability, engagement, and healing environment. So that being said, I think we are getting ready for a break, are we not?
Oh my gosh, we are. That worked amazingly well. Folks, can we just please get a big virtual round of applause for our presenters so far? Dan and Sharon and Brendan and Cherene and Travis, just so much information just came through in the first part of really understanding how Maryland is ready for peer respite to come and be part of our communities. So we do care very much about all of your wellness. So I would invite you to take just until 1:45, we're going to stick to our agenda. Take the next 3 minutes, feel free to turn off your camera, stretch, hydrate, take care of yourself, do some jumping jacks, whatever feels good to you. And when you come back, we are going to have 2 incredible guest presenters digging into what peer respite looks like in their communities. All right, folks, welcome back, welcome back. 3 minutes goes very fast, doesn't it? We are just honored and absolutely thrilled to recognize and to welcome two internationally renowned experts in peer support, in peer-run organizations, and in peer respite to our virtual stage today. Steve and Vesper, thank you so much for making time to be with us today and to share insights about how you've been able to successfully offer peer respite programs in your communities and help this model expand across the country and expand across the world. We are so inspired by your programs, and we are very eager to learn more. So in our journey, we're going to work our way north from Maryland, and we're first going to go to Rose Houses in New York with Steve, and then up to Kiva Centers in Massachusetts with Vesper. Thank you so much for being here, Steve, as the Chief Executive Officer of People USA, which is a peer-run mental health nonprofit that creates, provides, and promotes peer-driven crisis response and wellness services across New York State, but also across the country and internationally. Inspired and driven by his personal lived experience, Steve has spent over 2 decades innovating crisis response services and system-level improvements that raise the bar on customer service, person-centered communication, trauma-informed care, empathy, and positive expectations for people's recovery and wellness outcomes. There is an incredible list of firsts that you have guided the organization to do, but you're on camera and you're ready to go, and we're so excited to hear from you. So just thank you so much for being with us, and the floor is yours.
All right, well, thank you very much. It's very nice to be here, and nice to see everybody. Okay, so here we are. We're a People USA. We used to be called People Inc. We actually had a very close relationship with On Our Own in Maryland years ago when we first started. They helped to get us going here in New York. And so it's really nice to be here today. So next slide. So we are a peer-run organization. Our mission is to educate, support, and empower people and communities to understand, manage, and overcome mental health, addiction, and social determinant of health challenges. It's, we took on a bold mission in this organization because those of us that work here, which are all of us with lived experience, feel the need for systemic change so that people are treated with compassion and care and better opportunities for better outcomes for themselves. So that's who we are a bit there. Next slide. We've started some unique peer models. The respite house was really a first for us in New York. We started it 23 years ago, the first respite, and I did it in partnership with Cherene Mead at the time. And then we just kind of redesigned it a little bit to meet our community's needs. And so this is basically the respite that you'll see and hear about across the country that people are now operating, which is really nice to see something like this grow and be embraced by so many people. They have been studied, and you'll see some of the information in some of the research that you'll see. And also across Europe, they are also being studied now too, and expanding in Europe as we speak. So it's nice. Like I said, it's really nice to see something embraced and utilized and showing how it makes a difference in people's lives. So let's get into it. Next slide. Let's see. Okay, where would you rather go if you were in crisis? This is a hallway of a hospital, of course, where a lot of people, including myself, have been boarded in rooms, or not rooms, hallways like this during a mental health crisis, or would you rather go to the next slide? These are 2 of our houses' living rooms that are respite houses. And when I try to explain the respite house, I try to explain it as a bed and breakfast filled with compassion, love, empathy, and understanding. And that's, this is a much nicer environment, I think, to be in, especially if you're experiencing some emotional distress and trying to, get to a level of calm where you can think more clearly about yourself and about your crises and about your life. Next slide. This is another living room in another house that we have. We operate right now 4 houses, 4 respite houses. New York. But you can see I have, the professional music instruments are there. One of our other respites has a whole band room, an art room, things that help people feel more human when they come to the house, so that they can feel more relaxed. They can also show us a bit of their skills. We have a lot of musicians, a lot of artists that come through the houses, and it's really wonderful to sometimes be there. And once in a while I would sit in and jam with them as well. I'm a drummer, so I did put drums in the houses and made sure that they were there. But we do have the guitars, the keyboards, and then the art equipment is all professional art equipment. It's not crayons. Although people, I'm sure, love to do work with crayons, but I wanted to make sure that people were respected in terms of their age and what they would like to work with, or what mediums they would like to work with. So next slide. Okay, so the objectives of the respite, there's a little more detail of what we have created. It's really to prevent the avoidable psych ER visits and admissions. And I think Travis was talking about, when people often go to an emergency room, is that the best place for them to be? We did research 20 years ago, and then again 10 years ago, and we looked at why people go to emergency rooms. And it's basically because they're open 24/7 is number one. Number two is they feel that that's the place they're going to get the support they need. But if you're like me and many others, you get to the emergency room, you're kind of marginalized. You might be locked into a separate area of the hospital, and within a couple hours, you're so angry that you've forgotten about your crisis and you just want to get out of that emergency room. But in the research that we looked at, about 2/3 of the people that present in emergency rooms don't necessarily need that level of care. And it might even be more, but they really don't need to go to an emergency room. When I designed the respite, I wanted it to be a place where they were welcome, where they could talk about their crisis openly and honestly, even if it was suicidality or anything that was more serious for them, just to know that they have someone that they can open up to and trust. And I'll talk about those how we get to that level of trust in a minute. We do help guests understand what happened. We want to understand what happened that caused their crisis if they know. We increase their awareness of skills and resources. The staff, all the staff in all of the houses and all of our services actually are highly trained and resourceful and know all of the different services in the community, are connected to those services, so we can get people to the appropriate services, whether they are traditional or non-traditional services. It doesn't matter. We educate folks through mutuality about ways to improve mental health and overall wellness, so that they have can live a whole life, and examining the relationship between overall wellness and the guest's current situation. Next slide. We connect folks to services, as I said. We ensure that everyone feels comfortable, and they will be asked whenever they come to the house, are you comfortable here? Is there anything else we can do to make it more comfortable for you? And we just want to make sure that, I want to get beyond trauma-informed environment discussion to say that it's just a trauma practice that we do. It's a very trauma-informed practice that we serve people and ensure that we're looking at all aspects of every guest that comes to our houses are addressed. And that's very important. I think when people feel that they are important, and they are important when they come to our houses, they start to feel differently about themselves. And so that's what we promote a lot of, is helping people feel self-determined and important and safe. We want to prevent avoidable future hospitalizations, and we're 95% successful. And when we look back 2 years on former guests, whether they've gone back to a hospital emergency room or not, and they primarily do not. They come back to the houses, which is great, but they don't have to go into that level of crisis and go into an inpatient setting, which we like that. And it does break the cycle of going from home to crisis to hospital. And that's when I was in the hospital, this is what I was thinking about, of how do you break that cycle? How do you help people not have to go into those environments that can be very traumatic when you're in a psychiatric unit? Next slide. So why do they come? This is what they come in for. They're having acute psychiatric symptoms, as the traditional world calls it. Suicide, they're thinking of, adverse life patterns, trauma, addiction, chemical dependency, chronic health issues, strained relationships, social isolation, poverty, and economic stress. If you think about it, these are most of the things that people go to emergency rooms for. And it's nice to know that they have a choice. They don't have to do that. They can get a different and most times better level of care when they come to our houses to get the services. Next slide. So there are core characteristics that makes the house work. They are short term. You can stay 5 to 7 days. You can stay 1 day if you want. It's really up to you as a guest. And they are home-like. Like I say, they're like a bed and breakfast. We're constantly renovating and fixing up the residents as well to make them look even better. They're 100% operated by peers. There's no clinical components to it. And we have never really needed it. So it's been extremely successful in being 100% peer run. Highly trained, skilled staff. I can't tell you how much training we do. It's we've created our own training because we have helped open about 40 others in the country and in Europe. So we had to put a training manual together, and as we did that, we were very careful of how we did that and what the skill set was that we were looking for in the staff we hire, and the training they would need to rise up to that skill set and become well established and secured and confident staff. The Rose houses are open immediately and accessible 24/7, 365 days a year, and the service is 100% voluntary. When you go into a place that you choose, rather than being forced into a place, you're probably going to get more out of it. You're going to feel more empowered. And that's the whole philosophy behind it. Guests can stay up to the 7 nights. They can come and go for appointments, jobs, other essential needs. Next slide. And this is why it works, that we figured out. There really were 4 pillars that we discovered that helped this all to work for us. And, number 1 was engagement. It's how you're engaged and how you're welcomed into the house. And we, in the very beginning, scripted that so that people felt, comfortable coming into a place they'd never experienced before. Welcome to the Rose House. We are so glad you're here. Let us tell you who we are and what we're about. So the staff will start this little education process while having discussion with the guest and figuring out why they're there and what it is they're going to need. We don't rush to do paperwork. We tell people, if you don't want to do any documents right now, we can do them later. We're going to explain what every document is, why we're doing it, why it's important. So there's a lot of transparency in the house, but the engagement is so key. And I often talk about, when you've gone to clinics or other programs, partial hospitalizations, that engagement is usually a Medicaid window or an insurance window where you have to kind of flop your card down and give them some information. It's not always the nicest waiting rooms and things like that. So to really start with the engagement being a nice place to walk into, engaging and welcoming and friendly, makes a big difference. Then there's the environment. What kind of environment are we offering people? And everyone should deserve just a very safe and comfortable environment to come into. So that's what we did. We, like you saw the pictures of the houses and the living rooms, bedrooms are the same too. They're all just very comfortable and engaging and nice to be, invited into. The mutuality is the lived experience. We are peer run. We're 100% peer run. And when you can share with somebody your story or your experience, it makes such a difference. And some of this I learned when I was actually, after my recovery, I started working in a hospital emergency room, and I treated people the way I thought they should be treated, not the way they were treated. And I would steal food in the best parts of the hospital for them. I would make sure that they're comfortable. I would make sure that they know what was going on. And that's where I learned about this mutuality, because I started to open up and share my own lived experience with people that were coming in. And immediately their heads would pick up and look at me, and you'd get all different kinds of comments. but there was comfort in that, and comfort in knowing that as difficult as their crisis was, they weren't alone. And that was so important for people to understand that they're never alone when they're in our services. And then there's the ultimate philosophy of recovery itself. Do we believe it? Do we believe in it? Do we live it? And our philosophy is, yes, we do all of those things. My staff are just absolutely wonderful, where they have embraced recovery. Because what'll happen is when you open a respite, the first thing that the traditionals will say is, well, what if somebody comes in and hurts themselves, or tries to kill themselves, or tries to hurt others, or becomes violent? And you're getting all these negative questions that come in the what ifs. And my what ifs were always, what if somebody comes in and just loves the greeting that they get, and loves the environment, and loves the support that they're getting, and gets more out of that to where they're willing to share more with us, because that's important. When people can share and feel free to talk as they want to talk and speak what they want to speak about, they start to heal. It just starts to work for them. When you validate that, so powerful. You know, we want to always validate people. So what we're doing with these houses is not just, and I'll talk little bit about that. I don't have a lot of time, but you're not just opening a house. You're opening the house to the community, and you're opening up a community to think differently. And that's the idea that I started with, was how do I get the community to embrace the house, but also how do I get the community to shift to a recovery focus of embracing recovery rather than fearing symptoms and fearing the persons that they're serving. And so the house offers a lot more than just a respite for the individual. Next slide. So the guest criteria is pretty simple. You know, we say living with significant mental health or co-occurring issues. We don't really know, and we don't really care. So we just, you know, we had to do that to get it approved through the state to get a house open. This was back, 22 years ago. But they wanted some kind of criteria. It says, okay, somebody lives with, whatever. If you're experiencing a crisis, it's your crisis. And if you want to come to the house, then you come to the house. And if it's a mutuality of understanding of why you're there, you're coming in. Now, medically stable is important, because we have had people come in that are dealing with untreated diabetes or untreated heart conditions, or things that are not, that are out of our scope of service. But we don't kick them out of the house. We bring them to the hospital if we have to, or the doctor, or whatever medical treatment they may need, but then they come back to the house. The resident has to be of a designated service area, which meant they had to be from a certain county if it was funded through that county. Well, I can tell you, we've had people from all over the country and different parts of the world have come to our houses. We've never kicked them out, but again, we had put certain things in because we had to, follow rules of the counties and the communities that we serve. They do have to be 18 years and older. We are starting to work on opening a youth house as well, but that's in the near future. Care for oneself and one's personal needs, highest level of care offered. Persons need education in independent living skills, and sometimes people they don't know how to cook. So of course, my staff are going to cook with them and start to teach them some of those skills. We help them to maintain the beauty of the house. They can help with, doing laundry or cleaning, the rooms up or something like that. We want the guests to really own the house as well, so that they're not just thinking about their symptoms and their crisis, but they're also thinking about how they can help to make the environment better for everybody. Understanding, and signing necessary documents. I mean, we do have to have some documentation that shows the efficacy and the efficiency of the house. So we do ask for that. Living in permanent housing was what I originally started with, because I really wanted to focus on people that were experiencing the crisis, not so much from homelessness or not having a place to go to, but just having that crisis that many of us have had when we've had stable housing. However, over the years, working with my staff, because I'm not the one, I don't want to just make all the rules up for this. I asked them, what do we think about bringing homeless folks in? Because we're going to have to let them go back out to homelessness. And so that's a very transparent, open discussion we have with every guest, because we do get folks that are homeless into it. And my staff have a hard time wrapping around, letting someone go back to it. But if people are willing, that's their empowerment, their self-determination to make that decision for themselves. But then they get to also work with our other services, which are housing services. And so we've actually grown in that area as well, as providing housing for many people. Willing to adhere to a guest agreement. I didn't want to call them rules. I wanted to have an agreement where we agree as the house operator and you agree as the guest to respect the house, respect each other. And that's really what it comes down to. So we don't have a list of rules. It's more of agreeing how we want to treat one another while they're there. It is 100% voluntary and self-referral. So that means if an officer comes across someone that's in the community that's in need of some crisis care, the officer will take the phone and hand it to the guest or potential guest and have them call us. And within an hour or less, they can be in the house. And it's not just, I just gave police as an example, but anybody that calls us and says, I'm trying to get somebody into your house, the first thing my staff will say is, can you hand the phone to the potential guest? Because it's their decision, not yours. Capable of self-preservation, of course, and then sex offenders is a challenge because we are in neighborhoods. We can't always serve, everyone that comes through, but we do have mobile services that we would provide if people are on sex offender registries. Next slide. So here's some demonstration of cost savings. Some average annual costs of operating. This is just one of our smaller houses that operates at $1,065,000. It has been a cost avoidance of psych hospital usage, pretty dramatically. 7.2 mil compared to 1.65 serving, the number of guests that we serve, I think is a huge cost savings. And that's now being recognized by state governments and federal government, where it is being licensed and put under a Medicaid option, which is not my favorite thing in the world, but it is going to allow for more folks to be served as long as the philosophy and the fidelity of the model stay true to what we've created. Next slide. I do want to mention that, yes, they are co-ed. I just saw that question pop up. Yeah, they are co-ed because, we're serving adults. We want people to respect one another. We do have safety, in place for that. We've never had any major issues with it. So, and our houses, as we're expanding our houses, we're making them a little bigger, a little bit more separation for people. So it's working out. I mean, there really are no issues that we're having. So that's the basic premise of the house. There's so much more I could share, especially experientially of what we've learned. But I think it gives you a little bit of an idea of what we do and how they're run. So thank you.
Oh my gosh, Steve, that was such a window into the world of peer respite in so many ways. And I see questions coming up through the chat. And we have some time we can do some questions now. And then after also we hear from Vesper about Kiva Centers, kind of both of you together if you're willing. But since you mentioned it, can I ask, what do you wish people asked you about peer respite that speaks to some of those lessons learned along the way?
It would really be about how does it work? What works? What makes it work, and what happens to the people after they leave? Because one of the things that's important to me is the follow-up. How are you doing? So we check in with all of our guests as they allow us. We ask them for permission, but as they allow us, we have found through the 8 dimensions of wellness that their quality of life has improved from not only the visit at the house, but also we follow up with our other services as well. And they've stayed connected to us. Many of us stayed connected to us. But I just want people to know how well it works. And that's what's important to me.
Amazing. I know there's definitely questions coming through the chat about some kind of specifics, but would you also speak broadly to that question of, in our world, sometimes data and documentation are essential ingredients in getting this to really happen?
Yeah.
As well as those community neighborhood partnerships with kind of, literally where are you, but also how are you interfacing with maybe law enforcement or emergency rooms, places where folks go who maybe aren't aware of peer respite or have questions about it because of thinking of that documentation and data mindset. Do you have any
Yeah.
broad comments on that?
I do. It takes a lot of work, a lot of engagement with community providers, with police departments. We actually do all of the crisis intervention team training in several counties here in New York. So we've trained a lot of officers on what we do. And we've also opened the first, and I don't know if it's the only, but Peer run crisis stabilization center, which is a 24-hour facility that people can go for 23 hours, 59 minutes, and it's a wellness hub there, which feeds into our Rose houses. But it's really building community around the idea and the concept of what we do. It took me, when I first opened, it really wasn't popular with hospitals and community providers until they actually started to see it work. So it took a good 2 years in my first house for it to take hold and people to trust it. That put us at the table, and not only are we now at the table, we're helping design the community services because of the work we've done. And it's we're at the head of the table, which is nice. Making those decisions with county governments and state governments on how they should operate their services and build integrated systems of care that work.
Amazing, truly amazing. I hear very much the thought of it takes time. And lived experience is everything. You have to experience a peer respite working to understand like this is possible. It speaks to I think the evolving shift around moving from sort of treatment or control or compliance or coercion into understanding healing and community, and that is so much more powerful. I see a lot of questions in the chat and sort of very specific questions that seem to do with staff training and kind of guidelines about how do folks come into the house and how do folks come out of the house. And I also wonder if you're able to stay, if maybe we also hear from Kiva Centers about their programs, and then these questions of what do you do if someone wants to leave and you have a concern, or what do you do if they're around safety and how to create safe environments. So it might be interesting to go through some of those very on the ground pieces together, because something I understand is every house is its own house, right? Like there's guidelines, but every house is its own house. Thank you so very, very much. That's really tremendously inspiring. And we are doing great on time, folks. Vesper, shall we take some questions, or would you like to share? Shall we continue our journey to the Northeast?
Yeah, I mean, I am open. I am open. So.
Oh my goodness. Well, wonderful. That would work beautifully if that works for you. Thank you so much. Let me just say, as we travel further up the 95 corridor, it's just my great pleasure to warmly welcome back our next presenter to the stage, Vesper Moore, the Chief Operating Officer of Kiva Centers in Massachusetts. And I hope that you all had the opportunity to join us at our virtual conference almost a year ago in 2022, where Vesper spoke about the future of mental health, disability rights, and peer support. And if somehow you missed that, it is available on our YouTube channel. You can watch the video. But Vesper Moore is an Indigenous activist, trainer, writer, and psychiatric survivor, and they have been widely recognized for their advocacy in bringing the perspectives of MAD, labeled mentally ill, neurodivergent, disabled people, and psychiatric survivors to national and international spaces, whether as a lecturer for universities, a consultant for the US government or the United Nations, or being at the forefront of legislative reform to shift that social paradigm around mental health. But as Chief Operating Officer, Vesper has been really instrumental in the Kiva Centers' growth and their operation of 2 peer respite centers that offer rest and reflection for folks experiencing emotional distress. So thank you so much, Vesper, for being with us again and the floor is yours.
Thank you for having me, as always. And I think it's great being in this space with both Steve and Cherene. I admire the work that you all do so much. I think our organization does as well. Our peer respites are relatively new. We started in 2021, but we are fast growing and continuing. As you can see here, we kind of have an opening slide. This is just some of our community members gathering. In the corner, there's a drum circle, us being outside. We do a wide variety of things, which I will describe, but just before we get into peer respite. Next slide, please. So a little bit of history of the Kiva Centers. Our organization comes directly from the civil rights movement. We started as an activist group, a mental health activist group called Empower in 1987, directly from the Mental Patients Liberation Front. You can see some images of us rallying over the years for different causes, and as well as different founders rallying. In the corner, you see Judy Chamberlain, who was one of the founding members of Empower, along with Pat Deegan and several others. I think it's important to start here, really, because this is for us at the root of why we do this work, why we do peer support work, because we are an organization that's run by psychiatric survivors, trauma survivors, people in substance use recovery. With these variety of experiences, what the commonality there is that often society can view us as disposable, and that's a part of the larger issue, and that's rooted in a lot of different things. But that's led us to the creation and the implementation of so many lived experience peer run initiatives that we have come to grow and know over the years. Just, I guess, in description of the pictures, the very top, that is Empower folks protesting electroshock treatments when electroshock was prevalent. And then below, that is us advocating for peer support expansion in Massachusetts, and advocating for voluntary peer support, peer run services, because that is at the root of what we do and what we care about. Next slide, please. So the meaning of the word Kiva. The word Kiva is a word that represents the ancestral chambers of the Hopi people. This is a picture of a Kiva. I actually took this picture. I climbed into that Kiva and re-emerged. It was about 113 degrees outside. And you can go in, and it's a cool space where you can sometimes focus, meditate, go deep within yourself, and come out healing yourself. So Kiva, you can think of Kiva as a metaphor for self-determination, for autonomy, for personal journey, trauma healing, personal journey with healing. The turquoise K that you see in our logo, that is a representation of freedom, because it is a feather. And amongst a lot of indigenous tribes, the feather has always represented liberation. Next slide, please. So our mission. This is a photo of us gathering with a few of our friends in the Netherlands, actually in 2019, I want to say. And our overall mission is, as a peer-run organization, we work with folks with different social impacts, such as mental health conditions, substance use recovery, trauma. However a person may define their experience or what brings them to our doors really is up to that person. We're willing to meet them in a lot of ways. Kiva Centers, we operate a recovery learning community. We operate 2 peer-run respites. We do certified peer specialist training for the state of Massachusetts. We do peer bridging. We do quite a variety of things, which I'll delve into a little bit further after. Next slide. And here are the pieces. So we also do technical assistance. So we also have been supporting folks as they've been looking to start peer-run respites in different places like Indiana and Chicago. And we also do a lot of coalition work amongst peer workforces, because in Massachusetts, we have community health workers, we have peer recovery coaches, we have family partners, we have certified peer specialists, we have many different professions that maintain distinction for one reason or another. And it's very important that we emphasize the value in those differences of those roles, as well as the value of the similarities and how we can co-collaborate as communities. Next slide. Here's a fun fact about peer respites. Studies have shown that peer respites can reduce hospitalization by 57%. This is from some early studies in California. I am sure there have been far more studies since, and I'm looking forward to seeing some of the work that On Our Own Maryland is doing to really further research peer-run respites, because we need to show what we already know, which is this model works. It works for so many out there. And in terms of, kind of what we have discussed so far, which is the idea that by folks going to peer-run respites, they aren't interrupting their lives. There isn't a significant change. Sometimes during a hospitalization, someone's medication can be adjusted, someone's housing and or employment can be compromised. There are a variety of things that can happen. So by having a peer-run respite as an intervention in this way, we are really coming in and supporting people and maintaining that autonomy in their life and really fostering it. Next slide, please. So our peer respites. Our Caraya peer respite, the word Caraya is the Taino word for rest and reflection. It's symbolic of the moon, actually. It's the word for the moon spirit. I'm a Taino person. Our executive director, Brenda Vizina, she's a Hopi person, which is why we have the concept of Kiva and why we have the Taino concept of Caraya. Caraya, specifically being in Worcester, Massachusetts, is more of we have more of a Hispanic, Puerto Rican, Dominican community. And a lot of Puerto Rican and Dominican people are of Taino ancestry. So for us, it was very important as a way of being culturally responsive to name the respite Caraya and to speak to that experience. Our Juniper peer respite is in Bellingham, Massachusetts. And Bellingham, the juniper berry, the juniper tree, the juniper bushes specifically can be found and are native to those lands. The juniper berry is has been known to have healing factors, and the juniper tree itself is very resilient and strong. So you can see again these metaphors rising. But overall, our peer-run respites are crisis alternatives to the traditional system that you know. We are 100% peer run, from our board of directors to our executive team to our management team to everyone in the community that helps sustain Kiva Centers. Next slide. Here are some pictures of our Caraya peer respite. So you can see the walls are colorful. It is a home environment in the more, I would say, rural area of Worcester, just outside of the hustle and bustle of the city center. But at the same time, it's so close to all of the resources and all of the creative things that Worcester has to offer, like the Worcester Art Museum, fantastic brunch places, many different things that people can immerse themselves in. Because I think something that's important is that although people stay with us for 5 to 7 days, sometimes more if they request an extension, we like to do things together as a community. So usually on Saturdays or Sundays, we could go bowling, or we go to the Worcester Public Market and we have boba tea, or we're sharing a meal, or we're doing a lot of these things together, because we do actually believe that it is in collectivity, it is in community that we find healing. And as you can see, every room that we have at our peer respite, they are private rooms. They all have small refrigerators if a person needs refrigerated medication, or if they need to refrigerate something in their space. Everyone can access their own space, come and go as they would like. People manage their own medication at our respites. And it's important to mention that, like, when a person is unhoused and they're coming to our respite and they're staying with us for a period of time, they can stay a maximum of 30 days. That's what the state will allow us to do. And we have done that on a few occasions. One such example I can think of was we had a guest who was trying to get into a sober shelter, but couldn't get into a sober shelter unless if they stayed in what's often referred to as a wet shelter for a period of time. And the challenge with that was that it was going to impact their sobriety. So instead of staying in that shelter, we were able to work with people on their team, and they were able to stay at our respite and then go to a sober shelter. That's a good example of a sustainability model, because had they gone to the other shelter, it would have compromised their sobriety, and they wouldn't have been able to go to a sober shelter, and they would have likely stayed unhoused longer. Luckily, this person has been housed for 2 years now, so it's exciting stuff. Next slide, please. As you can see, more pictures. We have a garden, both in the front of our Caraco Peer Respite, and in the back, we're trying to build garden beds. We do believe in like peer support and agriculture and like working together, and like sometimes you're, having your hands in the dirt and really working together in that way can be healing as well. And then this is one of our community spaces, generally where we have peer support groups, or if people just want to have a conversation, share a lunch, or take a snack to the other room. In this space, people can kind of utilize it in the way they would like. I think it's so important to mention that often when people are in inpatient environments or other environments, they do not have the same autonomy of space. So we do believe that it's so important to be able to know that like this is your community space. Yes, you are a guest here for this period of time, but we are sharing and working together in this space as much as possible and as much as you would like. Next slide, please. More pictures of our Caraco Peer Run Respite. This is our kitchen area, as well as our living room area. Next slide. So here are some things that our guests say about our Peer Run Respites. This is one review. The caring and compassion I received here, both this time and the last time I was here, was more healing than every other program I've been in. And I think, something that allows that to be attained is really, one, having people who understand to some degree the experience that the person is going through because they've been through something similar. And then I think it also has to do with the environment. Environment matters. Something that we train our peer respite advocates and we train certified peer specialists in, and that we train peer support workers in a lot of contexts, is the idea that the presence of positive messages does not matter as much as the absence of negative messages. And what that means is that if someone's saying like oh, you're this space is all yours, feel at home here, feel welcome, it can be eliminated or really not have as much of an impact if there's another sign that says you are a flight risk. Stay in the other room. You are not allowed to leave this area. You are not allowed in this area. So we teach that idea, the idea that environment matters, and that there needs to be an absence of negative messages as well as the presence of positive messages. Next slide. Here are some photos of our Juniper Peer Respite, which has been open for, I want to say, a month and a half now. This is our Caraco Peer Respite that you had seen before is a 6-room peer respite home with 3 bathrooms. We also do offer mobile peer respite to folks across the state of Massachusetts. That mobile support is usually up to 4 hours at a time maximum, but can be as little as 30 minutes or whatever the person requests. We do that both virtually and in person. And usually what that support is comprised of is that we meet a person in the community at a location of their choosing that is mutually agreed upon. And then from there, we really get to listen, and then kind of figure out, how can we support you? How can we work together? And where do you need support when you are going through an intense instance of crisis? So our Juniper Peer Respite is in the Bellingham community, which is much more rural than Worcester. And I think one of the great things about the Juniper Peer Respite is that this is the only mental health resource in that town. The closer resources to Bellingham are usually in Dedham, or they're in Boston. They're usually an hour, 30 minutes, 40 minutes out. So this respite has been really crucial for the community that has been so isolated and so far from various resources in Massachusetts. Next slide, please. You can see we have our dining room table, other rooms. And as you see on the bed, we have these welcome baskets that usually have clean towels, snacks, a variety of snacks, shampoo, conditioner, things that people are looking for. And again, we have a refrigerator in each room, small refrigerators on the nightstand. Next slide. And then here are some more things that our guests have to say about our peer respites. In one survey, we had asked, how is the quality of the support you received to all of our guests? And they reported that 94% of them reported that they received a great quality of support. And then 6% were undecided. And I think, often when folks do join us, they can be coming out of an intensive inpatient environment, crisis stabilization environment, clinical respite, another space, or sometimes directly off the street. So if they are in a space of trauma, it can be hard to interpret the type of support you received, or like, oh, wow, this is a nice environment. This is the first time I've experienced this in this way. Next slide. Another quote from one of our guests. The peer respite advocates, first and foremost, there aren't enough words to describe these people. They are lifesavers. I also love the welcoming environment, the cleanliness, and the groups. So this was in response to, what did you enjoy most about your stay with us? And this person had reflected that it was really the relationships with the people who worked there. I think a key to that is that we maintain transparent and mutual relationships. I like to say transparent first, because when someone's in a working role, even though the goal in peer support is for the relationship to be as mutual as possible, there is still a level of separation and difference because you are in a working role. So often we are transparent about that, and then we work to be as mutual and as reciprocal in that relationship as possible. Next slide. And then again, a similar percentage, which I found interesting, we had asked our guests if they felt safe when they stayed at our peer respite, and 94% felt safe and 6% felt undecided. Next slide. I see a question in the chat, and just to briefly answer, our peer support groups, we do open topic peer support groups, we do living with suicide peer support groups, we do hearing voices peer support groups, we do trauma-centered peer support groups, we do grief and loss peer support groups, we do intergenerational trauma peer support groups, we do art groups, we do music groups, a wide variety of things. Generally in our respites, we have djembe drums, and we have bongo drums, and we have guitars, and we have a variety of art supplies, and then we have trained facilitators who come into the space and facilitate some of these support groups. So another thing that one of our guests had to say about our peer respites is it's very welcoming here, and it's not like an oppressive, uncomfortable setting. I feel genuinely supported and cared for here. I feel like all the mental health all mental health treatment should be like this, because it's the only thing that makes sense. A safe and relatable community is what I've always needed. In the past, I got the opposite, disguised as mental health care. So this was like a breath of fresh air. I hope to bring the sense of safety I've gathered here with me in the future. This place is a gift. So as you can see, this person's reflecting on prior experiences. I will say most of the folks who are recommended to be at our peer respites are usually Department of Mental Health involved, Department of Corrections involved, unhoused. A lot of folks have been in inpatient care settings for a long time. A lot of folks have been in inpatient care settings for a short time. So it's really a wide variety of people who have different experiences. But I think regardless of what their background and their experiences, we treat each guest the same way, with the full intention of, this is a community space. You can express what you need, you know. We have so much to offer. But also take time to rest, take time to take care of yourself, and together we are working as a community to reflect, to build, to find what we are looking for ourselves. Next slide. Yes.
I think that is it. Does that work for you?
That works for me. Yes. Thank you.
Oh my goodness, Vesper, thank you so much. I just, Steve and Vesper and Cherene, every time you tell the story of what people find in a peer respite, it is just a breath of fresh air and such life in full color. When I think we look at, in some communities, just the absolute lack of healing-centered, like responsive, thoughtful spaces that really provide that opportunity to understand that this is part of life. We're all on a journey navigating our lives and encountering challenges. And what we need is someone to listen and a place to feel welcome and seen and safe and supported. So just first, thank you so much. There's things coming in from the chat. I know folks, feel free to use your buttons or your hands, however you want to say thank you. But if I can ask for Vesper and Steve and Cherene, that maybe we have a group discussion of some of these questions that have come through in the chat, moving from, you know, someone shows up at the front door, what happens, all the way through to a systems approach about kind of transforming our framework for support. So if we can start, when someone comes to the front door of your respite, when do you say no? I hear from all of you that the most important thing is to say yes as much as possible, but are there times when you say no? And if so, who gets to say no? That's open for everybody.
I can count on one hand how many times we've said no. We really don't. So it's, you know, we do a pre-registration with everyone. They call the house first and we ask them, you know, how we can help them, what they need and whatever. Every staff person is trained to welcome guests in. So there's nobody, you know, at the higher levels or anything making those decisions. If it is questionable, then we will, you know, move it up to a supervisor, just to have a discussion around it. But we really not had the issue of having to say no to folks that have come in.
I would say similarly, like we often do not say no, and a lot of our peer respite advocates, like they usually reach out on a call, they talk to the person. I saw in the chat someone had a question about accessibility needs. We usually talk about accessibility needs when a person's first coming to us, and I think usually from there we're able to determine how best we can support that person. But yeah, more often than not, we don't say no. I'd say if there were circumstances, it would be if it were like medically impossible for us to like support someone in the space in the ways that they needed. We've had a couple occasions where it was like someone needed a nurse on standby 24 hours a day, 7 days a week, like in the space in that way. And we weren't able to offer that level of support.
And very similarly for us, it's a shared decision. It's not a hierarchical decision. And it's based on a lot of things like space. Is this the environment that actually feels safe and healthy for you? Is this a comfortable space for you? You know, sometimes people come and they don't know what it is. They're looking for a clinical support. They're looking for something else. And that's okay, completely valid. We want to support you to get the support that feels right to you. We have very few people that it's not the right fit or doesn't feel like the right fit. So very similar to Steve and to Vesper, it's very, very rarely like a no. In terms of the accessibility question, for us, we have widened several doors. We have an accessible bedroom. We have an accessible shower and whole bathroom actually was designed with folks that utilize wheelchairs and came in, helped us design it. We had disability rights come in and do an evaluation of our space and give us a report and recommendations. And we modified everything that we could modify in an old house to make sure that it was accessible, including a ramp and things like that.
Incredible. In a system where so many of us hear no, right? No, you don't qualify. No, we don't have space. No, this isn't the right fit. No, you don't have the right thing written in your chart somewhere that you may or may not be able to see. To hear all three of you say, we say yes. You know, like as much as possible, count on one hand of the nose. That is just such a shift and really, really powerful. On the heels of that, so one of the, I know as we look from a systems perspective and crisis services, there is this idea that sometimes choice goes away. Often choice goes away and it's taken away from folks. We know also if we look at all the systems of oppression that impact people of all identities and why and how that happens. But one of the gleaming pieces of peer respite is the idea that it's voluntary, it's choice-based, that folks, you know, are able to say yes to that you create safe, empowering spaces. And in some of the research about, you know, focuses on rehospitalization or being able to divert folks out of involuntary or coercive environments. So can you talk about, have there been times when someone has started to be caught up in a situation where their choices are being taken away, and how the peer respite has created a voluntary environment? Because I think there's a big question about what's that moment and when can you move into a peer respite instead of having to go through this often very traumatizing experience of not having control over where you're going or what's happening to you.
I'm going to give grace to whoever would like to answer first. Steve, would you like to go?
You know, the question you're asking is, does the respite take some of those freedoms away?
Oh, I'm so sorry. That wasn't me being clear. How and when can the respite become involved with folks who maybe the law enforcement showed up in response to a concern, and there's that thought of either we're going involuntary or we're making voluntary? How does your peer respite interact with law enforcement or the judicial system in any way to create a pathway into the respite? I apologize for not being clear. Does that help?
Oh, yes. Yeah. It's very simple, actually. I mean, that's what I mean about the community understanding who you are and what you do. They start to understand the criteria in the community. So the officers all clearly understand the criteria of the house, and they can say to somebody themselves, look, I could do one of three things. I can arrest you, which I don't want to do. I can bring you to an emergency room, which I really don't want to do, or I can bring you to a respite. So it's your choice. So they're still giving choice to the individual, and I'll tell you, 10 times out of 10 it'll be the respite when they're you know, being engaged in the community. The same with if they're in clinics or if they're in, you know, traditional services and they're starting to, you know, ramp up in whatever it is going on for them. They're given the choices and they're given the understanding that this is completely voluntary. Again, the de-escalation is volunteering. The de-escalation is support and being embraced, you know, and you know, and supported to come into the house. So it doesn't become as big an issue, I think, as most people would think it could be.
We've started working on a community policing response. So we work with the local police departments. Usually they know about our respite. Sometimes they'll be like, okay, I'm going to put in a recommendation for a mobile with a person, and we will meet with them sometimes instead of that same response. We are building it out more. You know, Massachusetts, I find, as a Commonwealth, is you know, a medical hub. So there's a lot of inclusion of clinicians, social workers in their response, and we're constantly advocating, please include more peer supporters, please include more peer supporters. So we are getting there and we are seeing it, but it's still, we're still in the implementation process, if you will.
And I'll just add another layer to that, in addition to what both of you have shared, and that's guardians. So we have a lot of conversations with folks that want to come and they have guardians, they're living at home with a family member, and they're wanting the freedom to be able to come to a space like this rather than end up going to a respite. And so we've had many, many conversations with the person, with whomever they find to be their support, whether it's their guardian, whether it is a clinician, whether they are police involved, whatever the case may be. Right, there's fear that people have when somebody chooses an environment like the respite, and so we have to demystify some of the fear and assuage some of the fear so that people also feel comfortable that people are coming into a safe space and that we value and honor their safety in addition to valuing and honoring their freedom. In terms of police involvement, the respite is a part of CIT training. And so police officers absolutely are connected and know about it. One of the things that police love about us is we never call them. We are, as an agency, are a zero force and zero coercion agency. We do not call police to come and intervene unless it would be absolutely an unusual situation, because our job is to literally support people through distress. That's what we do. And so the police love the fact that they're in an environment that they know we are going to be there with people and help them work through it. And we are not just going to call the police to come and intervene when things get difficult.
Thank you all so much. Those were like such concrete examples of how the kind of what we may take for granted as the sequential intercept, right? Kind of like, well, once you start this process, it just keeps going, and about all those opportunities that come from the, you know, whether it's the hospital, the emergency room, the mobile crisis team, the CIT teams, the police officers, the neighborhood, everybody understanding what does a peer respite do and feeling comfortable and confident in making those connections. So that speaks, I think, to the need for really strong community engagement. And as we're going around, you know, speaking with stakeholders in Carroll County and Howard County and Baltimore City, it's also understanding in each environment. Vesper, I really appreciated the way you talked about the peer respites being very grounded in what does that local community look like. I know Cherene, in some of the conversations that we've had, you've talked a lot about neighborhood and neighborhood engagement, just that's a huge piece. And I would like to talk more about that as we move up into maybe operational questions. But one more sort of on the ground, you know, someone who is in the respite and maybe they are experiencing a lot of barriers. They don't have housing, or their housing's unstable. They're dealing with medical or physical health or disability, and maybe not getting all the support that they need. Maybe they don't have enough clothing or food or their vital documents. Can you talk about how you're, at an organizational level, how do you make sure that your respite is well connected with the services or the supports that people might need? To your point, Steve, earlier about, you know, I wish people asked what happens when folks leave the respite, like having those successes of creating that pathway back into health and home and independence and community. So how do you operationalize that?
Learn and grow. Oh, go ahead, Vesper.
Yeah, I mean, it can be rough though. It's hard sometimes because I think you know, it's how engaged the person wants to be after they leave the peer respite, if they want to continue to receive those resources or not. And what I was going to say was that we sponsor 7 community fridges in the city of Worcester, and we're building more community fridges in Southbridge, and we're building more community fridges. And if you're not familiar with what a community fridge is, a refrigerator that is generally outside, that is sponsored by an entity nearby that can keep it powered with electricity and all of that. And we stock all of those fridges with food. We also have community closets in all of our recovery learning communities. We have a peer bridger that meets with the person if they would like before they leave the peer respite, so they can continue to be connected. And we always offer mobile for those resources. We're also working on a trans closet. So if people need binders, breast formations, or need to get on hormones and need to work with a peer supporter in order to get there, then we sometimes provide those things directly, or we're able to recommend them to someone.
Yeah, I would just add to that my organization, we have well over 120 employees now that are in different levels of service. So we have mobile, we have forensic mobile teams, we have regular mobile teams, we have recovery staff that are just out in the street. So we have care coordination now. We also provide housing. We have over 200 units of housing, and we're building housing as we speak. So it's, the respite creates some interesting opportunities, when you start to step back and see where people are really struggling. We're tied into the FQHCs, all the food security agencies, all the shelters. It's how well you build your infrastructure of your organization that's going to serve the people once they leave the respite. And so nobody gets left behind, in our organization. And we are strong advocates for constant change and improvements in the system itself, from us right up to the governor. So we're knocking on every door trying to make it better for everybody.
So from a big picture answer, there is a combination of building out your continuum within your organization to making sure that people have access and supports in a variety of different environments. We have an outreach team that works in street community, in encampment sites. We have a forensic team that works on diversion, reentry, going into prisons and jail, but prevent incarceration. I can go on and on. We also have 130 employees at PRN with a variety of things that we do. So that's building out our own continuum within our organization that is accessible to anybody. And then, Vesper, as you're talking about, I think one mistake would be to think about a respite as a discrete program, not a part of a larger community, right? You have to be a part of community. There are other resources, supports, efforts, movements, grassroots things that are going on within your community that you want to be a part of the fabric of, not just a discrete program that is doing something over here. And so any way that we can contribute to our community, like the fridges, like Narcan distribution, in making sure that those are available in a variety of environments, like needle exchange, like food insecurity, and supporting homegrown healthy food and access to those things, and then connecting to a larger community of services and supports, it is really critical that a respite is a part of a community, not just discrete from it.
Thank you. That is a charge out, and really speaks to, I think, work that I'm glad GBRICS, the GBRICS project in Central Maryland, that is trying to create is creating a regional crisis system, understanding that just because you walk 2 miles that way doesn't mean you should suddenly lose access to services or gain access to services. The work at the state level of understanding, how are we making sure that our system is well connected, and specifically though thinking about data, to your point, Steve, about being strong advocates for the expansion of peer delivered services, peer run services, and alternatives, and all of that requires funding. How do you all use documentation and data to prove the case for peer respite, for getting that buy-in, for being able to illustrate the impact that you are making? And is there anything you don't do around documentation or data that you think would be surprising to maybe folks on this call or folks who watch this video later?
The thing we don't do is we don't care about diagnoses, that's for sure. We care about the individuals that are in front of us and who we serve. And as far as data, you want to show the efficacy of the service you deliver. So we work with consultants nationally on building those outcome, data points so that we're measuring, is the like quality of life. We're not just looking at, are we reducing crisis? Is the quality of life changing? Is it getting better? We're also putting our funding into research and evaluation. And then we have a quality assurance department as well that looks at the quality of care and services. So we're doing the surveys, we're getting the testimonials, we're doing everything that Vesper and Cherene are also doing to ensure and gain the credibility and the respect that we all deserve in what we've created. So data is very important to us.
It is very important. Otherwise, it feels like theory and like a really nice thing to do, but not practical or safe or effective. And so I think we all have to, Steve, Vesper, myself, all of us that are in the peer respite community are always having to find ways to validate, justify, but also tell the story and tell the reality of the story. I'll tell you some of the things we don't do around data. We do not do any assessments. We do not require referral. We don't do clinical assessments. We are not interested in diagnosis. We don't do level notes. Things that feel clinical in this type of environment are not what we do in this environment, which is really, really important as a part of this. We actually also go insofar, and maybe both of you all do this as well. When somebody comes into the respite, there is space to be and decompress and to orient. We are not doing paperwork on the front end unless somebody wants to, but if they truly do not want to, we will get to all of that. That's not what drives this environment. What drives it is that you are in an affirming space, you're in a safe space, you're in a comfortable space. You can begin to even ground yourself in what is happening in your body, in your mind, in your life, all of those sort of things. That doesn't come in the paperwork. The paperwork will come, but we are not paperwork heavy in any way, and that is also very intentional.
I think just to add, we follow a community co-authoring model of documentation, which is basically the information that our community wants to be, the narrative that is told by the survivors is what we use in terms of information to continue the growth of peer respites, to tell the stories of the people who are there as much as they would like, right? So I think what's important, and I had mentioned this more in depth in my keynote, is this idea that we need to reclaim this idea of like information being collected about us, and instead, what narratives do we want to tell to kind of change that paradigm, that idea that we have about information collection. So for us, often we will sit with someone like, what is the story you do want to tell? Like there is no pressure here, but like if we're doing a study, if we're working on something, right, that's so important. And I'd say that the only data that we usually collect is from like when someone's like, oh, this is the neighborhood I'm coming from geographically in Massachusetts, or if there's any demographic information, it would be what they are comfortable with disclosing. And the only reason why we collect that is for purposes of affirmative action. Because if you don't know like what communities you are supporting, if the community you are supporting is predominantly white, if it is predominantly men versus women, if it's predominantly many of these things, it's like how will you know that unless if you take an evaluation and a look at yourself? How will you take that action to change, to do better, right? So for us, it's again how much a person is comfortable with disclosing, and usually we're very transparent about like we're working together on this.
And I want to just add one more thing. In all of this, whether it's a data question, a safety question, a how people come to us question, peer respites are about access, right? So many environments are not accessible to people. And we have to be really considerate of the barriers for access that people have had throughout many years of service involvement. And that barrier could be a referral barrier. It could be an assessment barrier. It can be I have to share information about myself that I'm not comfortable barrier, or these people have to know I'm here barrier. Whatever those barriers are to access, we have to be very intentional and very cognizant about and try to find that yes, which means that we have to be as low barrier as an option as we possibly can be, because frankly, there are not many other low barrier options available for people that are experiencing crisis. So we have to embed the yes into how we operate so that people feel comfortable coming and
Embed the yes. That's a bumper sticker right there that we can probably apply in so many ways to what we're doing everywhere. On the heels of that question, being able to say yes also means having the resources to do that, to not be beholden in different ways, so that you can run your programs, but also create communities that are responsive, that are mutual, that are collaborative, and that are effective in healing. Can you talk a little bit about how your respites are funded, or maybe considerations for how you sit in the system, that demystifies that aspect of how do you make such an accessible alternative that should be the mainstream for supporting people?
So I'm going to say something that might feel a little bit unusual. Some of you have heard me say this before, but we turn down more funding than we accept as an organization. And the reason for that is because all money is not good money. I see some of you like, what? All money is not good money. We have to be very cognizant about what we are exchanging for funding. And if what we are exchanging for funding is the integrity of peer support, it's the integrity of a respite model, it's the ability to have accessible space, it's the co-creation environment. If we are giving that up for funding, that is not something as a CEO that I'm willing to do. So we're looking for funding partners, not just funding streams. So that's another thing that I just need to name as far as we are concerned. Our funding for our respite comes from our county. We've had a long-standing relationship with our county that funds a variety of different things, and they fund it because they truly value it, and they know that we need this in our community. Other respites, well, actually, I'm going to because we're all three funded a little bit differently. So I will just stop and say, we are funded by our county, philanthropy, contracts, technical assistance, consulting. We're always looking for a variety of ways to bring in our funding so that it is flexible.
So I'll say that we were originally funded by the state of New York because they didn't know what they were funding, and that was good. And then we got counties to pony up and start to pay for the other facilities that we had. We also did get foundation dollars. However, the respite was embraced by the state of New York Office of Mental Health, and that's dangerous because they wanted to license it. So the only thing I could do is work with the state of New York on building the license for respite. And what I infused into that license was the power of the peer support, not losing that. And I hired a consultant to come in also and said, I want to be treated like a third grader to understand what I have to do to create this unfortunate medical model so that it can still maintain the integrity of peer services and be completely peer run. And we did it. And so now the state is licensing these and paying for these, which is, unfortunate. It's not where I ever wanted to go. But if I didn't get involved in it, the state would have just bastardized it and it wouldn't be anything close to what it is. So at least we can maintain that integrity. And then through our coalition in the state, we are in touch with all the peer respites that exist now so that we work with each other on maintaining that integrity of peer support, of true peer support of what it is. And what it is allowing us to do on the other end of it is now I'm buying more houses and building more respite. So I'm using it for the good that I can figure out on what good can come from this. And it's allowing us to expand in those areas But it wasn't something I constantly fought the state and saying, please don't license this, please don't. And of course, they did. So it was a battle. It was really hard, but I think we did pretty well in maintaining the integrity.
Yeah, I think it's always a challenge. It's always a challenge when it's funding. I agree, both Steve and Cherene. It's really like it is building a lot of these models embedded into state funding or other sources of funding. I'd say in agreement, Cherene, that we do not accept dollars unless if it is pretty much on our terms. Our respites are funded federally. The funding is awarded to the Executive Office of Health and Human Services, and our respites are funded as Model A blended capacity respites in the Commonwealth of Massachusetts. What we have done is that in our master service agreement, what we would do, right, versus other clinical entities is variety is extremely different. So like word for word, we said, we will not be trained to administer medication. We will not collect this type of information. We will collect this type of information. And then it was basically like that master service agreement. Every time we add on to our respite model, it's already built in. All of our values, everything in a signed contract document. So as we continue to expand. Now, we have had some new opportunities. We got some private investors who are looking at home properties for us, and then we are renting from them at a certain rate. So that is what we've been looking at in terms of expansion. We've also been looking at foundation dollars, private foundations that are looking at funding us in part. And I think the reason for that is always diversify your funding. It's so important. And don't let it all be state or federal. Definitely allow there to be portions that are private endowments and otherwise.
Yeah, in other states, just so you all know, there are mental health block grant dollars and or substance use block grant dollars that will pay for peer and respites. So if we look around the country and we do a scan, which is what we're doing and we're going to put in the report, obviously funding is part of the question, is how are other peer and respites funded? And we are going to add that section so that you can see what it looks like around the country.
Thank you so much. For thinking about, what is peer respite? How is peer respite? Why is peer respite? These are the pieces, the building blocks of creating this. On that too, resources are certainly not just dollars and cents. The most important resources are people, right? People every day who have the training and the skills and the passion to work in a peer respite and create that transformational healing experience. Could you all talk a little bit about, I think maybe 3 aspects of this? One is you all alluded to the importance of training, of training of peer support specialists. And are there any particular considerations around training that you'd like to highlight, or you want people in Maryland to think about? The second is the question of certification. I know every state certification looks different. And there are lots of conversations happening about that. So especially to that idea of when you have a contract or you're being licensed or you're dealing with the sort of logistical paperwork dynamics of this, how do you conceptualize or consider the idea of being certified, whether it's certified in peer support or certified in any other type of program? And then the third piece of that would be, how do you make sure that your employees are supported the way that they need to be too, because we're all in this together. So 3 questions, kind of training, content, what you'd like to highlight, certification, how does the role of certification, what does that play in your organizations? And then thirdly, about workforce, how do you recruit and retain and support the folks you need to be able to create such wonderful programs?
Well, I can say this much. First, we certify peer specialists in the state of Massachusetts. We've done that for a long time. I think there's a lot of controversy in general about the professionalization of peer support as it exists, as it does, all of that. I think you actually need both. You need informal peer support trainings, if you will, and professional peer support trainings, if you will. And again, that's thinking of the entire concept of professionalism being rooted in racism and a variety of other things simultaneously. But I say that also because these models of how it looks to be a certified peer specialist and work on an inpatient unit, what it looks like to be a certified peer specialist who's kind of working in the middle of a police situation, right? Navigating all of these different spaces and having a training that speaks to the history of movements, peer support, and all of that is so critical. And that's what our training provides. But I'd say in addition, people take a variety of trainings, whether if that be our trauma-informed peer support training. We offer living with suicide training. There's also alternatives to suicide training and hearing voices training. There's also intentional peer support training. I train intentional peer support, and that's such an important model. But I think for us, we have a list of trainings, and then people kind of choose their path. Because some people prefer to do wellness recovery action plan and work in that way, and some people are more like, okay, it's more about the connection, the worldview, and how we're working together. And then circumstantially, if you're trained in both, it might be different in each situation. So that all of that's to say that we have trainings that prepare people for certified peer specialists if they want that to be their path. If they don't, there are other trainings they can use. Yeah, I'd say that's us on training.
Steve, you want to go for it? Want to talk about training, and then I'll talk about training?
Sure. A lot of training. We subscribe to Relias training for the basic OSHA and safety and all that, onboarding training that needs to be done. We are certified peer specialists in New York State, and we are the curriculum writers as well that have designed the certification in New York State. And then we had to develop our own respite training itself, which I use worldwide, but on how to train staff to learn how to listen, how to engage, how to, just really how to work in the house safely. And then there's a whole safety component in there. When I say safety, a wellness component really for the staff, because, they're working in a critical environment and they need to be supported. And so our agency is extremely supportive of all staff. We have very creative staff that create different types of strategies for the houses, for the mobile teams, for, wherever the staff are working on maintaining that wellness. The open door policy is here, of course, for staff to, decompress if they need to, or talk about their situation or their circumstances. A lot of training that goes on. And then there's some traditional motivational interviewing just to understand what that is and how that works, the intentional peer support, the recovery action plan, trainings, all the good stuff that came, out from Pat Deegan and everybody is here as well. So it's pretty constant, for the staff, and then refreshers as well, so that they stay, up on all the current trainings and things.
All the same things, all the same trainings. I'm just going to add a couple things. Any willing person should not work at a respite, right? So I say to people, just because I have hands, I should not be a surgeon. Just because you have a diagnosis does not mean you should be a peer supporter. But unfortunately, as peer support has grown and training has become a little bit of wildfire in certain states like mine, we have 14 different training curricula in my state alone, 85 different trainers. It is unfortunately becoming any willing person can become trained as a peer supporter. What that does for us as a peer run organization is we have to support people to unlearn, we have to retrain, we have to untrain, we have to be very intentional about who is employed. While we operate 18 different programs, the respite is is its own thing. And not everybody can be in a space that people are coming in experiencing crisis, number one. That you can find that balance and not try to fix it, minimize it, or explode it, that you can validate and sit with somebody else's distress. Like all of those things need to be considered, right? I am a high energy person. You don't want me working in an inpatient unit. I promise you, you don't. And so my caveat to all of this is there's a ton of training that we do, all the same ones, from intentional peer support, all the way through Hearing Voices Network, all the way through Alta Suicide. All of those trainings we require of our team members. And there has got to be the right fit for this type of environment, and not everybody is a right fit, and that is completely okay.
I think just to add on to that is that we had to develop characteristics of the staff we need for the different services that we provide. Because I was one of those people when I first started 24 years ago, if you said you were a peer, I hired you. And I was like, oh boy, was that a mistake? So, you have to build those characteristics into your interviews and what your expectations are of your staff.
Phenomenal. I know that's, I see a lot of nodding heads, and there's certainly, that's with the expansion of the peer workforce in so many ways, and the recognition of how critical it is for people with lived experience to be embedded in every level in the healthcare system, whether or not peer is part of your job title or not, to be really human driven. It brings up these great questions about what does that mean, and how are we a number of the things you talked about, being transparent, being mutual, being honest, focusing on choice, making sure that that we can speak, this is what this looks like. Do you want to be here? And if not, that's okay. And if so, that's okay, right? Like all paths are working out. To that, I have seen there's been great questions in the chat, and it's not my intention to skip over any. There is a great question that came through about accessibility also when it comes to folks who are hearing or seeing, and that makes me think about, as a peer respite operates in a community and more folks hear about it, want to be involved, I imagine there's also things that have maybe been surprising or you didn't anticipate, or where you had to build out in a different way. We talked earlier about making sure that things are accessible in terms of mobility. Are there any other things that have happened related to the pandemic or not, but that were unexpected situations in your respite, and how did you work through those? Go for it.
Yes. We had someone who stayed with us who was under a guardianship, and their guardian resigned, and they wanted to leave the state, and they couldn't leave the state. So a lot of our peer respite advocates, myself included, supported this person through this guardianship case. It took like more than the usual amount that a person would normally stay at our peer respite, and we were able to extend and extend and extend well beyond our maximum capacity. So this person stayed with us, I think, for close to 3 months, and we were able to, adjust a temporary guardianship situation with someone that they trusted, because the guardian who had resigned still had legal control over this person's life. I think people don't recognize that, like even once that happens, that's a circumstance. So that was hard, and throughout the pandemic, we've been doing our unhoused peer support project, which is, there's a 1.5 mile stretch of Boston, right, that is an unhoused encampment. It's off of Mass and Cass. Often it is referred to as Methadone Mile. We've been trying to change that name to Miracle Mile, and we're working on a documentary about this and all this. And we've been supporting people in those circumstances. There's been collaborations with tiny house projects and many other things that are happening in Massachusetts. But all of that's to say that we've had a lot of interesting situations, but I'd say the most interesting is probably that guardianship circumstance.
So we have had a couple of folks that were fleeing sex trafficking. One directly was fleeing, and somebody that we know very well recognized this person in distress on the street and was able to say, we need to go, and I know where we need to go. And it gives me goosebumps just to talk about it. And the person showed up at the respite. And there's a lot that goes along. If you've never worked in that community and understand the safety risks and the really serious things that need to happen, there's a lot that needs to happen under those circumstances. Tamala, you're shaking your head, yes. And another person that was in an underground temporary space because they did flee sex trafficking. Both of these people were abducted from other states and had been involved in sex trafficking for many years and found a way out. So those are a couple of those types of, we get situations all over the map. I will tell you, we've had two incidences, I will say, at our respite, and both involved guardians. Interesting that Vesper, yours involved a guardian as well. In both scenarios, when we reflect back at what happened, we were able to realize that while the person said they wanted to be there, they felt pressured by their guardian to give the guardian a break, rather than them being there for their own purpose of respite. And we did not follow our own process, right? Sometimes, like, our hearts are just so big and we want to love and support and engage and do all of these sort of things, but we can miss some really key pieces of information that we needed to have, or just some of those signs that we needed to have. So two individuals landed in our respites that both felt pressured to be there, and both scenarios created some safety risks in the space. And so we have learned a lot from the guardianship issue, and are still learning, how do we navigate when folks have a guardian, that they are truly there in a non-coercive way and want to be there.
Yeah, I would echo that, where there have been people that have been voluntold to call the respite and come in, and it's not a comfortable situation for anyone. And so we've had to address that. And then the domestic violence issues that come up that aren't at the surface, that my staff have been good at, figuring out, as well as the sex trafficking work, has probably been the bigger challenges that we faced. One other challenge we face is, unfortunately, a hospital that doesn't understand or care sends people to us literally physically ill. Not sends them to us, but they call us and they say, "Can I come to your respite?" And we bring them in, and it's they're in horrible physical shape. So we go to another hospital. We work with a more friendly hospital somewhere else when that situation occurs. But that's another thing to just be aware of, is where they're coming from. Are they volunteering to come in? You may not get that all the time.
Thank you so much for sharing all of those stories. That it speaks to and makes me think of the complexity that we all have in our lives, but often when we're coming into a particular kind of system or service that might have been traditionally siloed, that there's not always even an awareness. I mean, I think we all know in our person, like in our lives, that human lives are complex, and we have families, and we have histories, and we have situations and things we lived through. But that when the doorway is very narrow, or the scope of the support is very narrow, you miss all of this. That I know there were some questions earlier about, are your respites seeing folks who are coming maybe for the first time, or are coming once? Or do you see folks who are utilizing the respite? Cherene, you mentioned the idea of kind of anniversaries, or using the respite in a preventative way, maybe because there are all of these dimensions of stress or overwhelm or limitations that folks are navigating. Could you speak with that a little bit about what you see of respite as prevention, or respite as something that becomes a big part of someone's life? Or do you have folks maybe who come once and then don't have to enter this, the mental health service system in a way? Could you speak a little bit about that, those pathways?
Yeah, I mean, I can say this much, that we've had folks who have returned, but more often than not, that's like a handful of people. And I think that's because we become like a trusted resource where they come back again. And I would say that more often than not, if people don't end up returning to the respite, they're usually still engaged in our peer support groups that we offer online or in person, or they call our peer respite warm line, or sorry, peer support warm line, or they've taken our certified peer specialist training. They might be working in peer support. They might be doing something new. So usually people continue to be involved in our community in some way. And if they need support and they don't necessarily want to go into the respite, they've requested mobile. I've seen that numerous times. Yeah.
Yeah, I would say the same, as Vesper says, and we have the houses become natural warm lines anyway, so they don't always have to come back into the house. But we welcome folks when they come back. It's good that we can continue that journey, together. But they are mostly involved in all of our other services, so it's nice to, keep that continuum going for them.
Yeah, and we also have a 24-day, 7-day-a-week countywide warm line that we operate. And, we have, 30 employees on that line. And so at any time, as frequently as somebody needs, they can call and talk to a peer supporter. So I think that has been helpful. In addition to, as you both were saying, being a part of any classes and groups and activities, we operate 95 different groups and activities every month in our community and online. So there are a lot of access points. Here would be the exception for us. There are people in our community that are on a do not serve list, whether it's a literal list or a in people's heads list, because they are considered to be too dangerous, too unwell, too complex of life experiences. As an agency, we are the safety net in our community for anybody to be supported no matter what. So your history is irrelevant to us. There's no diagnostic criteria and there's no referral. That means that we end up very frequently have been kicked out of every service or have walked away from every service. We are the only game in town, kind of like Vesper, you were talking about that rural area with the respite. That's the only option. We as an agency are the only option for many, many, many people in the community. That means for our respite, it's either jail, hospital, which you'll end up in handcuffs and shackles anyways, or our agency. That means that if you have to have repeat stay at a respite, we'll do that all day long. If it means that you have access, supports, and an opportunity to reimagine your life that does not end up in handcuffs and shackles. So we do have a handful of people that come back to the respite for a variety of different reasons. We've also had school teachers that have planned a respite stay during a break. Can you imagine being a teacher right now coming off of COVID? And for folks that have those types of positions, to have police show up or mobile crisis show up or to be hospitalized is a career ender for so many people. So to have a warm line that's anonymous and have a respite where none of that is going on a record becomes an accessible option for people that are first responders, having other types of roles, and they'd be concerned about showing other type of space.
Thank you all so much. The dimensionality that's just erupted, I think, in the last couple of questions has been really revealing and really exciting of understanding, like, when you have a peer respite in your community, it unlocks all of this other knowledge and skills and support and understanding of what's going on in our communities. I was thinking about the word engagement. There's a lot of focus on how do we engage people with services? How do we keep people engaged? And then I thought of the idea of a gauge is literally, right, it's a way of measuring. And there are different gauges. There are different sizes of gauges. So the whole piece of this engagement isn't just getting someone from point A to point B, but it's for them to be able to make the choice of, it sizing up or sizing down, of going over here. It's that ability to suss out and measure for yourself, like, what's the right, am I a teaspoon today? Am I a tablespoon? Am I a cup? Am I a gallon? Like, what do I need so that I can move forward in my process? If I can bring us together maybe for a last question, which is thinking about young people, whether we're talking transitional age youth, folks from that sort of like 18, 16, 14, and into late 20s or early 30s, or folks who are younger. I know in Maryland, there's been efforts about being able to lower the age of consent for behavioral health services, recognizing that we know when we want or need support, and that home may not always be a safe place in various ways of understanding safety. Could you talk about where you see the role of a respite now or in the future when it comes to young adults who may not have all of the same legal rights and maybe dealing with those guardianship issues, but who certainly need support, or maybe are not housed or have been kicked out of their homes, and really could benefit from something like a respite? So respite for young people, what are you seeing? What are you feeling?
We're fortunate that we have a couple of housing providers that provide not necessarily respite for the youth, but places for the shelter for them to go to. And their houses, they're not typical shelters that you would think of for the youth. But we did design a youth and family respite in Brooklyn that's been operating and pretty successful. And so we're now bringing that up to our area to get that set up. And we want it to be, definitely respite for the youth, but also respite for the families. So we're building family rooms so that the family can come and stay together and work together on an open dialogue and on their situations, and trying to come to resolution of all living together and living well together.
The hardest part, oh, go ahead, Vesper.
Sorry. I was just gonna say that, it's interesting when we talk about young adult peer support, just in the way of, I think when people think about young adult peer support, they inherently think it has to be more clinical. It can't be as autonomous in the same way as it's but I beg to say that it's a transparency first model of yes, I'm an adult with a certain level of autonomy. Even if you are a young adult, if you are above the age of 18, you have different legal rights, right? So we have a young adult advocacy training that talks about all of this and how we support young adults. In terms of a young adult respite, that is something that we're interested in. I think similarly to what you were talking about, Steve, we've been working with a youth shelter and a few other young adult environments, but we've been looking at that model and seeing how it could work. I do like the idea of family and open dialogue as well.
We have been asked to open a youth warm line, a youth respite, several things with young people. And here's what I say about it. Number one, anything that's going to be developed for young people has to be developed by them. I'm a 50-year-old, almost 50-year-old woman who came into systems when I was 13, but that was 37 years ago? And there's nothing I'm going to be able to create that is going to be relevant to young people if they're not the ones that are creating it. And they're the designers and the leaders of whatever it ends up looking like. That right off the bat creates a rub, because I can't talk about anybody else's states or anybody else's community, but there is still a very, very large degree of paternalism when it comes to young people. And people need to be told what to do. They need to be managed. They need to be monitored, which is very, very different than what a peer-run organization is and what our values are rooted in. And so what I keep coming back and saying is, just like we do with all of our funding, these are the conditions under which we would accept funding. Number one, it is truly youth developed, led, designed, supported. Number two, as a system and a community, we have to wrap our minds around youth voice and youth leadership that does not default to paternalism and parental choice and clinical decision-making over the youth. If we do that in this environment, in an unlocked, non-coercive environment, it's no longer non-coercive, but the unlocked part is going to be a problem. Because just like the adults we have with guardians, there's going to be a pressure to be there and to again have somebody else have control and power over you, which is the recipe for safety issues. That's, people ask, how do you keep a respite environment safe? There's no there. We don't have any power over somebody. There's nothing to argue about. There's nothing to fight about. We are there as supporters, right? So it's a very different environment. If that were going to be changed in a peer-run respite, it would have to be designed very intentionally. And that's where I would be concerned about safety issues. So for me, it's about our community perception and our community embracing it, less about whether we should be able to do it for young people and with young people. That's a no-brainer to me. But can the community hang with it is the question for me.
Phenomenal. Phenomenal. I just cannot thank you all enough for taking so much time so generously out of your very busy lives to come and talk with us about Peer Respite today. You just have been so transparent and given us all a lot to think about the possibilities and about, you know, how do we stay true to creating Peer Respite the way that it should be and not get pulled into, how do we embed the yes and say no, right? Like there's that piece of it. Can I ask, if you all had a sign on your desk or on your wall or a rock in your pocket with a phrase engraved that really is the thing you come back to when you're faced with all these decisions about expanding, replicating, you know, managing peer-run organizations that offer a respite, is there a mantra or a phrase or something that always centers you in your decision making about how to move forward? Just, you know, if you could put it on a bumper sticker, what would it be?
My favorite is, it takes a discipline of hope. You cannot imagine or continue any of these ideas without hope. And you might feel it is hopeless, right? And it might be actually hopeless, right? But there is a level of what you may need in order to imagine a world that is different than the one we are in. And in order to do that, you do need a discipline of hope.
Our mantra for the organization is recovery. Hope greets you at the door. Recovery is the expectation. But my staff have given me a little plaque. I was just looking for it. Somebody took it. They keep taking it. Never quit. That's what they've, you know, and that's what it's been here. It's just never quit.
The word love we use every day, all day long. We have it in our environment. We do everything through love. And if we do it very genuinely and authentically, through love, you can't go wrong. Even the missteps are okay if we're doing it authentically. But I love the quote, I would prefer beautiful chaos over ugly perfection, right? It tells our team, take a risk, and it doesn't have to be perfect. It tells us that we are all flawed as human beings, and that's what makes us beautiful and gorgeous. And it means that we have to take risks as an organization and know it's not going to be perfect, and that's what's going to make it perfect.
To practice a discipline of hope through beautiful chaos and to never give up. Just folks, can we please have a round of applause for our incredible presenters today? So inspiring on every level. This has been an incredible symposium, and we again cannot thank you enough for your time, for your years of dedication to promoting and innovating and creating peer-run alternatives, for being an inspiration to all of us here in Maryland, across the country and internationally. Thank you to our project team partners, Cherene and Travis and Marcy, who are helping us steward through this feasibility study. Please do take our survey. Data does matter, as you heard. So Marcy's going to put the link in the chat. We know we were asking some questions, but it will really help inform our recommendations. We will be back to you all with those recommendations. If you want to stay up on what we are doing with the Peer Respite Study, I would encourage you to go to our website. Under projects, you'll see the Peer Respite tab. You can keep up with that. Please feel free to reach out to Marcy at peer.respite@honoronmd.org if you want to get involved, if you have some follow-up thoughts. We want to connect with and build this community of people who are advocating and demanding that peer respites come to Maryland. And with all of that, I hope that you all are taking good care of yourselves with each other. We are in this together. This is the start of an incredible journey.